breaking barriers and bridging the gaps between patients and doctors. Welcome to Brainstorming with the Docs and your co-hosts, Dr. Glenn Harrison and Dr. Kolby Condos.
All right, everyone, welcome back to this week's episode of Brainstorming with the Docs. I'm Dr. Kolby Condos, my co-host, the man on the other side of the screen, Dr. Glenn Harrison. How you doing, buddy?
I'm doing great. I'm ready for this one. This topic, and as we talked about it, why it's so important is because there's so many people searching for it. And I think there's a lot of fear, uncertainty, and I really want to dig down to the nuts and bolts on this and kind of create some clarity and some exposure. So I'm really looking forward to this one.
Absolutely. If this is your first time watching or listening and you have questions associated with your own health or health conditions and you're looking for some information, this is a good spot. Turn on the notifications, hit like and subscribe so that when we come out with new content, you're the first to get it. Without further ado, today's topic, my man, something both of us see very regularly in our practices, and that is, what is MS and what are some signs and symptoms associated with MS, and maybe what are some of the statistics. So why don't you start out, tell everyone what MS stands for and what it is.
MS, multiple sclerosis. I like to write on paperwork just MS because it's quicker.
Yeah, easier to spell too, right?
Yeah, easier to spell. I can't screw that one up. So it's a demyelinating disorder that's really an autoimmune disorder that's damaging and deteriorating the coating of your neurons, the coating of your brain cells. That's the easiest way to put it. And then if you lose this coating on your brain cells, well, naturally one cell, as I'm simplifying this, will just shorten out with another cell. And then you lose the ability to send information from point A to point B, because that's all a brain cell is. It's a fancy wire. Now, I know, Dr. Kolby, you can dive into that deeper. Is there anything you wanted to add to the MS?
No, I mean, you kind of summed it up perfectly. The myelin sheath is the insulator from the nerve, and it is what allows you to get messages really, really quickly from point A to point B. As basically the stimulus or the electrical impulse goes down the axon, if you don't have the insulator wrapped around it, you start to lose it, and it doesn't travel as far or as quickly. So then you start to get changes in the neurology. So you summed it up perfectly, right?
Yeah. And this is an autoimmune disorder where your immune system attacks yourself. It's not like a cold you just get. It's an autoimmune disorder, which is a whole another beast, but it's one of many different autoimmune disorders where your immune system turns on that specific material, that myelin sheath, that the rubber on the wire of your brain cell. So I guess to summarize, that's really what multiple sclerosis is. But Dr. Kolby, you're working with neuro cases all day, every day. Why is this topic so important? Why understanding it is so important? Maybe from a proactive, preventative, just an awareness standpoint.
Sure. I think that the awareness part of it and the uncertainty associated with it is the biggest deal for a lot of people, right? Because the symptoms can be so broad, because it can attack the myelin sheath anywhere. It doesn't have to be just in your brain. It can be in a peripheral nerve. It can be in your spinal cord. It can be anywhere. Anywhere that there's myelin, you can have, an MS attack. And when that happens, you can get weird things, right? You can get numbness and tingling. You can get sharp pain. You can get change in your vision. You can get changes in facial sensation. You can get, anywhere a nerve goes, you can get changes.
So weakness, I think.
Yeah, well, not just weakness, but like sensory stuff too, So you can get a lot of pain behind your eyes, like optic neuritis is a sign of MS. So people, a lot of times, because it's not a set, these are the symptoms of MS. It's in this little box. It fits here. If you have these, you probably have this. And people look and it's like, well, I could have carpal tunnel or I could have MS. Well, I could have trigeminal neuralgia or I could have MS. So it's the unknown for people. So they're always looking for the answers. I feel like that was part of the reason why it's asked about it, like it's asked to us a lot, but also why it was important for us to break this down a little bit is because there is so much information that maybe people don't know about it associated with multiple sclerosis.
So because the symptoms are so broad and so vague and not necessarily consistent, that's another characteristic.
Yeah.
It's consistent with autoimmune disorders. There's ebbs and flows in symptoms. So some days things are better, some days things are worse, whether it's a trigger or that's flaring it up or not? What do you see when we talk about episodal symptoms of MS?
Sure. So I have quite a few patients that have MS. Consistency wise, most of my patients that have MS had their first episode between 20 and 40 ish. Can be later, but normally it's earlier. And the last one that came in actually came in with like it wasn't severe, but was like episodic numbness in their hands where their hands were getting all tingly, but it was both hands. So I was like, okay, if you think if it's one side of the body, maybe impingement, but if it's both sides, then you have to look at like maybe a metabolic or a central component. So we did basically a cranial nerve exam, and we did a peripheral nerve exam and kind of put that together, and we had some incongruencies in there. So we actually ended up ordering some imaging and found that she actually had some active lesion sites which showed up. So that was my most recent case. Now, is that the only case? No, I have had patients that come in with like severe, pain behind their eyes. Their eyes hurt to look at things, and that's when you get like the optic neuritis, which is basically when the myelin sheath around the optic nerve starts to break down. It can affect peripheral nerves. I mean, it can affect any nerve. That's the importance of, if it's weird stuff, it's unexplainable, and you might have some questions, you need to ask someone about it, because getting the diagnosis earlier so that you can be proactive about your care is going to put you ahead long term in comparison to just sticking your head in the sand and hoping it goes away.
And yeah, I think that's a very important point, because the nature of autoimmunity, and that's what I work with all the time, is autoimmune disorders, is your immune system is attacking your tissues. And if it's attacking your tissues, some tissues you can't regenerate. This is a prime example of it. Neurons, you can't regenerate. You promote neuroplasticity, but you can't regenerate them. When the neuron is dead, it's dead. That's it. So if you can get to the front end of it and try to identify it and have strategies to slow it down before it starts eating up tissue faster and faster and faster, that is really it. And there are solutions for this. But maybe we're going a little too far in it. But the proactive part of it, I think, is very important to be aware of it. And I think you hit something exactly, because I've had quite a few MS cases, not as many as you by no means, but it's when things get strange. It's when you have these bizarre symptoms that are more neurologically based, but you can't fit them together. I think that is maybe a red flag, right?
Yeah, I agree completely. Yeah, if you can't explain it, or if it just doesn't make sense, or if there's, one of the ways that kind of the last time that I found it was, most time if people come in with numbness in their hands, they're like, oh, when I do this happens. Mm-hmm. I was doing this, and as a result, this happened. This patient was like, yeah, no, it's just like comes on weird, like on and off, and it's not consistent with anything. I can't really figure it out. And that's when I started trying to get at the history part of it, and it just didn't make sense. So we decided to order some imaging, and that's how we ultimately found it. So
yeah. So before we get into the diagnostic piece and maybe some genetic pieces that put people at higher risk, what are some of the stats? I know you were rattling some of them off earlier.
Yeah, so MS affects females slightly higher than males. It affects basically, I believe it was 3.6 cases per 100,000 for females and 2 for every 100,000 for males. But then something that I found interesting, and I think it's interesting because I live in the northern latitude, is it affects people more in northern latitudes than it does in southern latitudes. Now, why that is, I've read some research that shows some things. I'm not going to really put it out there. If you have questions, you can email us or whatever. But I thought that was interesting. I also thought it was interesting that they are not willing to make the connection of it being like a genetic thing. Whereas if you have, like your mother has it, you're more likely to develop it as well. But they did find that 15% of people that are already suffering from MS have one or more family members that also suffer from it. So I think that that's something that could warrant further investigation as well.
For sure. And just the nature of autoimmunity, there is some familial component to autoimmunity. So if we look at it broadly speaking as the autoimmune characteristic, but yeah, that northern Northern Hemisphere piece is pretty interesting. I'm originally from Canada, and MS cases are very high, and there was always the debate: what is the cause? Right? Is it sun? What are the differences? And vitamin D levels. Well, maybe not, but we do see higher levels of natural levels of vitamin D are inversely proportional to levels of MS. We don't know if that's just coincidental, or if MS is suppressing vitamin D, which it does a little bit, or vitamin D is suppressing the onset of MS. We don't know the connection between this, but Northern Hemisphere is a factor. So you touched on that genetic component, and I know you were kind of teasing the part of the diagnostic side of it. So you might have some bizarre symptoms, some family history. It doesn't make sense. It can't quite be pinned down, and you don't have a history of use of some body part that now it's bothering you, a trauma
Right.
or something. And then you go to a doctor. What are their first steps to diagnosing?
So it kind of depends on where you go, right? Sometimes it might just be a referral.
Yeah.
I did imaging. So I did brain imaging, and it showed active lesions, which showed up on the imaging, showing that the myelin was being broken down at some of the parts in the brain. And then you can do like a nerve conduction study, or an EMG, or an EEG, or you can do even like a spinal tap draw, where they look for myelin debris that's in your cerebral spinal fluid. I've never used that one, but that's also a possibility. So I think that going to someone who's not going to just brush it off, that's not going to go, oh, it's probably because you did this, someone that takes your symptoms seriously, or if it's been bothering you for however long.
And another thing regarding the statistics, a lot of people think these very degenerative diseases are like an elderly person's disorder, but this is happening, kind of that median age is between 20 and 40 we were talking about. So it's a younger person's disease, really, when it's first diagnosed. And then you talked about so when you're younger, that kind of, I don't want to say it puts you in a higher risk, but it means it's on the table. It's on the table.
Yeah. And I think that we have a history, like when we're young, we're like, think we're invincible, right? Oh, it's no big deal. My hand's just a little bit numb. Oh, it's no big deal. My face is going numb. It's no big deal. I just had a lot of pain behind my eyes. It could be a potential long-term thing. So the earlier you get it checked out, the better. Now, that's not saying that the condition couldn't be easily explained by something else, but I would rather know definitively earlier, like, hey, no, this isn't MS. Yeah, this is just whatever, rather than just thinking, well, it could be this. But then, 15 years down the road, they're like, hey, man, you have MS. You're like, I thought so 10 years ago or 15 years ago, and I just didn't do anything about it.
That's right. So it might be frightening to open up that door. But however, knowing, and we talked about this, you and I, Dr. Kolby, knowing doesn't change the diagnosis. It only gives you the opportunity to take care of it and control it and take control of your health. So those are some diagnostic pieces. One piece that you didn't mention was just blood, looking for antibodies. This is an early effort to being able to diagnose it early stages. So you're looking for antibodies, immune soldiers that are targeting that specific tissue. And there's many different forms of blood tests that can be done as an earlier stage, probably one of the earliest stages to identify before there's brain injury and things like that. So that's some of the diagnostic pieces. Now, if people have this, they probably should be, running to their primary and making sure that if you have symptoms, listen to your symptoms. If you have a doctor, whatever, a natural doctor, medical doctor, and they dismiss it, don't just accept that. Because I've seen it, I know you've seen it as well, Dr. Kolby, where things are dismissed and they don't dig into it deep enough. Maybe there's an insurance challenge or something like that. So don't dismiss it. What do you do in your clinic when you suspect somebody that might have these neurological conditions? You said you'll do imaging studies and all of that.
Yep. Yeah. So we just order MRIs or I've done it, sent out for EMGs before, nerve conduction studies, that kind of stuff. That's kind of where we start. I have, like I said, I haven't referred out for a spinal draw or anything like that, spinal tap. Fortunately.
Yeah. And then there's all sorts of different medications for someone. There's some, like any degenerative condition, the drugs can be very helpful and very nasty at the same time. I know you work with a lot of MS, and you're working with it, in conjunction with the medical doctors in many cases. Maybe touch a little bit, people, if they're listening to this, they're probably looking more than just a drug model. If you can give a quick synopsis of how functional neurology plays into this.
Yeah. So, yeah, I mean, I don't take a single approach, I guess. It's multifaceted. So we try to address, like, what are the immune triggers for you? Which we've talked about in previous podcasts.
We have an autoimmune podcast. So there'll be a link there. You're going to want to watch.
Yep. That one's good. So then we just look at really strengthening the area. So promoting like the natural physiology of the cells, especially the neurons, trying to remove any sort of immune system irritant, but then also trying to maybe strengthen those pathways that are being affected, or the portions of the neurology that are being affected, is the best success that I've had. Are you going to reverse it? Not necessarily, but can you make the stuff that's still there better? Yeah. So trying to improve just the stuff that's still there, make it as strong as we possibly can. And then remove the immune system irritants, because the more that you can basically stave off the occurrence of like active lesions where it's destroying the myelin debris or the myelin sheath, the better the patient's going to be.
Yeah. So there are ways to reduce the progression of the damage of the disorder. And if you can reduce or slow down that progression, well, your brain has the opportunity to reconnect its neural pathways with proper training. That's functional neurology. So you can strive to improve that function, maybe even get it back, or maybe one of the goals is just to preserve.
Yeah.
A lot of people, they're just trying to preserve.
Yep.
So,
preserve function and limit the lytic destruction.
Yeah. And so I guess if anybody's listening to this, they're not probably just clicking on this by a whim. They really have concerns about MS. Maybe they've been diagnosed. And I think it's important for people to know the earlier you catch it, the better. Always, always, always. And if there is MS, and it is diagnosed, there are solutions to slow some of this down. It's not a disorder that can't be helped. I guess that's the most important thing.
Yep, 100%.
Many people can get their lives back and slow this stuff down. Now, every case by case, there can be, of course, no promises on this, but there are many things, very powerful things that can be done.
I don't think that you're ever going to regret being proactive about it.
Mm-hmm.
You might regret the things that you didn't do, but I don't think that you'll ever regret the things that you did do.
That's very, very true. Yeah. Very, very true. So ultimately, I guess to summarize, the natural model and the pharmaceutical model, both approaches are going to be the best. Just one or just the other is never the full story. So and more questions about autoimmunity, listen to the autoimmune podcast that we have. That there's a ton of information in there. That alone can help you with reducing and correcting immune triggers.
You got it. And if you guys have information or questions or anything like that, you'd like to reach out to us, we have an email address. Our email is info@brainstormingwiththedocs.com. You can find more of our podcasts on Spotify, Apple, Google Play. We do have a YouTube channel. Brainstorming with the Docs is a YouTube channel. If you'd like to find information on our websites are www.northlakeschiropractic.com or www.drgharrison.com. Or stay tuned and turn on notifications, because these things are going to keep rolling out.
Yeah. And the next one's even going to be better.
We can hope, right?
All right. That was great, Dr. Kolby. I look forward to the next one.
All right, man. Sounds great.
Bye-bye.